I welcome you all to this episode of Conceptual Anesthesia. So, today we'll be talking about a very important topic which pertains to the critical care units, especially if you talk about MCQ point of view. Also, it's important. This is about toxicology in ICU. So, this will be a totally MCQ based topic, and I've already taken a talk on toxidrome, so you can all see through that. So, today we'll be talking about the MCQs. So first MCQ is which clinical feature is the least typical of anticholinergic toxidrome in critical poisoning? If anybody can attempt, you can write in the chat box about A, B, C, D. You can attempt in the chat box. So the correct answer is meiosis. So the anticholinergic syndrome is caused by drugs that block muscarinic anti-acetylcholine receptors. It's often summarized by the mnemonic blind as a bat. That means mydriasis is there and the pupils are dilated. Mad as a hatter, that means there's altered mental status. The patient can have confusion, delirium, or hallucinations. Red as a beet, the skin is flushed due to cutaneous vasodilation. Hot as a hair, so due to impaired sweating anhidrosis, the patient has hyperthermia. And dry as a bone, so due to decreased glandular secretions like saliva and sweat, this includes a dry mouth. And full as a flask, so patient has urinary retention. The patient may or may not have tachycardia and decreased bowel sounds. So when we talk about anticholinergic toxidrome, these are the clinical features. The heart rate is fast, the BP is high, cardiac rhythm is fast. So this is unopposed sympathetic tone, which may lead to hyperthermia and normal to high respiratory rate. But there is loss of cholinergic innervation and the patient secretions is dried up and the skin is also dry. Meiosis, it is the opposite of what is seen in anticholinergic syndrome. Meiosis is typical of cholinergic or opioid toxidrome. So when we talk about meiosis, just think about cholinergic or opioid toxidromes. A patient presents with acute cyanide poisoning from smoke inhalation in a closed space fire. Which antidote is preferred? So, what is the best possible choice amongst the four choices that are hydroxycobalamin, flumazenil, naloxone, or atropine? Anyone? Great going, Dr. Sajna. So, what happens in cyanide poisoning? Cyanides inhibit cytochrome C oxidase in the mitochondrial electron transport chain, induce cellular hypoxia despite adequate oxygen delivery, commonly called as histotoxic hypoxia if you go by the four types of hypoxia. This causes rapid onset of symptoms, including altered mental status, seizures, cardiac arrhythmias, and severe lactic acidosis. And smoke inhalation from a closed space fire is a common source of cyanide, as many synthetic materials release cyanide when burnt. And the preferred antidote for cyanide poisoning is hydroxycobalamin, and it's also called as cyanokit. It directly binds to the cyanide to form cyanocobalamin, that is vitamin B12, which is then safely excreted in the urine. It is rapidly effective and has a very good safety profile and can be administered empirically. So this is very essential that it has very safe thing and can be administered empirically if you suspect any smoke inhalation victim from a closed space when the patient presents with an altered mental status and the EBG shows acidosis. So in the management of acute poisoning in the ICU, which triad best supports the diagnosis of opioid intoxication? So any one of this which you think that fits in opioid intoxication? Anyone wants to attempt? The answer is hypothermia, hypoventilation, and meiosis. So opioids can cause central thermoregulation dysfunction, leading to lower body temperature. And the most dangerous side effect of opioid intoxication or opioid poisoning is hypoventilation or respiratory depression. They suppress the brainstem respiratory center and it manifests as a slow, shallow breathing rate. The patients often present with respiratory acidosis. Meiosis is a characteristic of opioid poisoning, as I told in the previous MCQ, and pinpoint pupils is what we mean by meiosis. So, when we talk about opioid poisoning, the various types of opioid that we know are heroin, morphine, fentanyl, codeine, and methadone. And the features of opioid poisoning are meiosis, bradycardia, hypotension, hypoventilation, and finally coma. And the opioid antagonist is naloxone. So you should remember all the antagonists also because they can individually come as a multiple choice question. So let us talk about other options because they will be coming in the other MCQs. So when you talk about hyperthermia, tachycardia, and dilated pupils. So if you look, there is a sympathetic stimulation. So it can either be a sympathomimetic toxins like cocaine and amphetamines, or it can be anticholinergic ones like atropine and tricyclic antidepressants. When we talk about diaphoresis, mydriasis, and agitation, this describes a sympathetic toxidrome because diaphoresis is not there in anticholinergic. When we talk about hypertension, hyperthermia, mydriasis, again it's like a sympathetic toxidrome. So we should know about all the triads and all the common symptoms, what is happening in each and every toxidrome. Again on toxidromes, which of the following toxidrome is commonly associated with seizures, hyperthermia, and muscle rigidity? Anyone? So the correct answer is serotonin syndrome. So this is a potential life-threatening condition caused by excessive serotonergic activity in the central and peripheral nervous systems. It results from a therapeutic drug use, intentional self-poisoning, or drug interactions involving serotonergic agents. So what are the agents that can be used? So commonly used is SSRIs and SNRIs. So MDMS can also come. So all of this can cause serotonin syndrome. Drugs like tramadol, linezolid can also be implicated. And the classic triad is mental status changes. So patient can have agitation, confusion, or delirium. There is autonomic hyperactivity. So hyperthermia, tachycardia, hypertension, and diaphoresis. Shivering can also be there. Seizures can occur in severe cases, and clonus is highly characteristic. So clonus, hyperreflexia, tremors, muscle rigidity. If these are there, think about this kind of serotonin syndrome. Interesting one. Why is magnesium sulfate administered in cases of prolonged QTC in toxicology? Anyone? So what does magnesium sulfate do? Yes, magnesium sulfate does stabilize the cardiac membranes, preventing torsades de pointes. So, what is a torsades de pointes? So, this is a kind of a ventricular arrhythmias in which what happens that if we draw isoelectric baseline, initially the amplitude increases and then decreases along with that. So, prolonged QTCs is caused by many drugs like antipsychotics, antiarrhythmics, TCAs, macrolide antibiotics, and antihistamines. They can prolong the QTC interval. This signifies delayed ventricular repolarization and creates a electrical instability in the heart. And torsades de pointes, as I told you, is a life-threatening polymorphic ventricular tachycardia, which can degenerate into ventricular fibrillation and cause sudden cardiac death. So prolonged QTCs, if it's caused by any of these drugs, can increase the risk of what we call as TDP, torsades de pointes. So magnesium sulfate is the first line treatment of TDP regardless. So this line is very important. Regardless of serum magnesium levels, we give magnesium sulfate, even if the magnesium levels are slightly on the higher side, because it is the first line treatment of this polymorphic VT, which can degenerate into the VF. Magnesium works by stabilizing cardiac myocyte membranes and inhibiting calcium influx. It directly suppresses early after depolarizations, which are the cellular trigger for TDPs. It also helps to normalize potassium channel function and slows the conduction velocity. It does not directly shorten the QT interval, but it prevents the specific arrhythmias that result from prolonged QT. So we should be knowing that magnesium stabilizes the membranes and is used in the torsades de pointes, even if the serum magnesium levels is within normal limits. A 45-year-old woman ingested rat poison, which is aluminum phosphide. It is a very dangerous poison. Which of the following is the most important initial management?